Hello everybody, my name is Dr. Richard A. Schulz from Roseman University College of Dental Medicine. This presentation is titled Before the Needle. What I have done is endeavored to cover the content of the Caries Management School Competency written by CODA. Upon graduation, a dentist must be competent in evidence-based detection, diagnosis, risk assessment, prevention, non-surgical, and surgical management of dental caries, both at the individual and community levels, and be able to reassess the outcomes of interventions over time. In dental practices across the nation today, we may have enough time to tell our patients to brush and floss in response to inquiries relating to what they can do better. Brush and floss twice a day, and we'll see you in 6 months, would be the typical dialogue between a provider and a patient. Dentistry today, particularly non-surgical dentistry, involves a lot more than simply brushing and flossing your teeth 2 times a day. That has been the anecdote that we have subscribed to as a body of practitioners for a long time. Although there are significant exceptions to this rule, a majority of us simply don't have time to apply the principles that the CODA standards are referring to. So instead of this being the end, how sad would it be if that was all we could do as dentists and hygienists and providers of dental care in this nation, was to tell people to brush and floss and we'll see you in 6 months. Of course, this requires a behavioral change, not only individually, but also on a national and international provider level. Professor Pavlov did some studies involving training behavior in a dog. He noticed that if he would ring a bell, the dog would do nothing except for hear the sound of the bell. When he placed a bowl of food near the animal, he observed that it began to salivate. So what he did was condition the dog. He would place a bowl of food on the ground and simultaneously ring a bell and notice the drool coming from the animal. After conditioning this behavior in the animal several times repeated, he then noticed that he did not have to place the bowl of food on the ground anymore. He would simply ring the bell for the dog to drool. We can apply that to ourselves in dentistry as it relates to non-surgical dentistry. We need to move away from simply telling the patients to do what is good for them. We need to use motivational interviewing, active listening, functional analysis, goal setting, and demonstration of appropriate behaviors. It is important for dentists to establish which option works best with each of the employees in their office, and for the dental care team to do the same with each patient in the practice. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. The mission of the CDC is to promote health and quality of life by preventing and controlling disease, injury, and disability. A disease is a particular abnormal condition, a disorder of a structure or function that affects part or all of an organism. It may be caused by factors originally from an external source, such as an infectious disease, or it may be caused by internal dysfunctions, such as autoimmune diseases. In humans, disease is often used more broadly to refer to any condition that causes pain, dysfunction, distress, social problems, or death of the person afflicted. Diseases usually affect people not only physically, but also emotionally, as contracting and living with a disease can alter one's perspective on life and one's personality. In the next 2 slides, I'd like to show you the leading causes of death by disease, both in females and males, according to the Center for Disease Control and Prevention. Heart disease, cancer, stroke, chronic lower respiratory diseases, Alzheimer's, unintentional injuries, diabetes, influenza and pneumonia, kidney disease, septicemia are all the top 10 leading causes of death by diseases in females. The top 10 causes of death by disease in males are heart disease, cancer, unintentional injuries, chronic lower respiratory diseases, stroke, diabetes, suicide, Alzheimer's disease, influenza and pneumonia, and kidney disease. We'll come back to these slides later on in our presentation. Take note how heart disease is the leading cause of death in both females and males across the nation. Additionally, take note of where diabetes is in females, number 7, and males, number 6. Many vaccines have been created to prevent diseases. We see no vaccine for dental caries on this list. When people are affected by diseases which we have vaccines for, they have a costly impact, resulting in doctor's visits, hospitalizations, and premature deaths. Sick children can also cause parents to lose time from work. Thus, the benefits of a vaccine can be viewed as far greater than the risks. The next topic that I'd like to discuss lies within this question: does disease discriminate? Ethnicity has been defined as an umbrella term which encompasses many components: religion, language, sex, gender diversity, father's education level, mother's education level, personal education level, class, health insurance or not, race, age, disability status, sexual orientation, family status, and dental insurance are some of the main focus points of the encompassing factors of this umbrella term, which we refer to as ethnicity. Of course, that's a ridiculous question because disease in and of itself does not discriminate. But I would like for you to consider at this time the different factors of ethnicity that may or may not contribute to discrimination when it comes to access for treatment of a disease. In applying this question to access to care, let's be mindful of access to preventive services and surgical services, as outlined by the CODA standard that we discussed previously. Preventive services are based on a biological and medical model, treating a patient with science and medicine before surgical intervention is required. Surgical services are necessary, and they're a mechanically based surgical model aimed to reduce, reuse, repair, recycle, and replace whatever organ or organ system has been affected by disease, as previously defined. Again, I'd like to remind you that this presentation is a collage of information related to the CODA standard referred to previously. Reiterated here, upon graduation, a dentist must be competent in evidence-based detection, diagnosis, risk assessment, prevention, non-surgical and surgical management of dental caries, both at the individual and community levels, and be able to reassess the outcomes of intervention over time. Accomplishing this objective requires more than just an old paradigm of instruction to brush and floss, and we'll see you in 6 months. That should never be the end of the story. Again, this will require behavioral change and starts with our own understanding of what health and disease is and how it applies both at the individual and community levels, which will allow us to reevaluate access to care, keeping all of this in mind before we have to pull out our needle for surgical intervention. Before we go into non-surgical dentistry, let's get a good snapshot of surgical dentistry and what we do as providers on a daily basis. In front of you, you'll see a representation of the tooth cycle, which starts with a healthy tooth. If we can intervene in time, we may be able to place a dental sealant on the occlusal surface of the tooth and prevent further tooth decay. Those of us who've been practicing long enough realize that sometimes other factors affect the health of a sealant, and sometimes sealants break down. If a tooth doesn't have a sealant, a small cavity may form on the occlusal surface, necessitating surgical intervention. Later on down the line, that filling may be susceptible to recurrent decay, depending on how it was placed, or the patient may have other factors affecting their teeth, which may cause additional lesions, requiring surgical intervention. Eventually, the tooth may require full cuspal coverage, and a crown or root canal may be necessary for the patient to retain the tooth. Unfortunately, sometimes teeth need to be pulled, resulting in an edentulous space. So now that we have a good idea of the tooth cycle and surgical intervention, let's talk about non-surgical dental services. And let's also talk about access. The following information that will be presented talks a little bit about preventive dental services and how much they are utilized by different ethnic groups. It's important to note that in this report, a dental prophylaxis, meaning a tooth cleaning and polishing, was not included because there's insufficient evidence that exists that the dental prophylaxis prevents tooth decay. And before we review these charts that discuss utilization of preventive dental services, let's define the word prevention as it relates to oral care. The contemporary definition of prevention is the art and science of managing the risk factors of each individual patient to promote optimum oral health. Before I show the slides of the utilization of preventive dental services, I'd like to draw your attention back to the slide I showed earlier as I posed the question, does disease discriminate? As we look through these tables, let us place a critical eye upon the utilization of preventive dental services and how it applies to ethnicity, this umbrella term, and how it is related to access to care. Table 1 is the Medical Expenditure Panel Survey of the United States in 2009 and covers the prevalence of dental visits and receipt of preventive services, topical, fluoride, and sealant, or both. Keep in mind, this report did not include a prophy for the reasons that we stated earlier. You can see I've highlighted in yellow the populations who underutilize preventive services, statistically speaking. Again, the table goes into more factors that may affect access to dental preventive services in a statistical fashion. Statistically speaking, Hispanics with a family income poverty ratio of less than 100 and whose head of household has less than a high school education experience the least amount of visits for preventive services of children and adolescents aged 0 to 21 in 2009. And you can see that white non-Hispanics with an income poverty ratio of greater than 500, college graduate level education of the head of the household with any private health insurance and private dental insurance has a significantly higher utilization of preventive dental services as a child or adolescent age 0 to 20 years old. The following figure reveals the disparity between surgical dental care utilized and preventive dental care utilized. Again, this information came from the Medical Expenditure Panel Survey of the United States. You can see the drastic difference between dental care utilized and preventive dental care utilized. So the question is, why? Why is so much dental care surgical in nature instead of non-surgical? In 2009, less than half of children and adolescents had a dental visit in the past year, and approximately 15% of children received sealants or topical fluoride. These low levels of dental use have persisted throughout the preceding decade. Sealant prevalence was low among children with teeth likely to be eligible for sealant placement. Less than 1/3 had sealants. Socioeconomic groups with low levels of dental use, non-Hispanic blacks, Hispanics, those with low family income and low educational attainment by head of household, also have been documented to have higher prevalence of untreated decay than the general population. So my question to us is, who is going to treat these people? How are they going to gain access? What causes them to have such a low utilization rate of dental preventive services and dental services overall? The low use of dental care and preventive dental services among children at high risk for dental problems is likely associated with financial barriers and low oral health literacy. These findings in this report indicate that children with private dental insurance were more likely to have a dental visit during the past year and to have received preventive dental services than children without private dental insurance. A recent report found that low oral health literacy in the United States created obstacles to recognizing the risk for oral diseases, as well as seeking and receiving needed oral health care. This report also found that very young children, aged less than 3 years old, were even less likely than older children to use dental care. Among these very young children at risk for tooth decay, early establishment of a dental home might reduce dental treatment costs. Ongoing changes in the U.S. healthcare system offer opportunities to improve the use of clinical preventive services among infants, children, and adolescents. This means improved access to oral health care and oral health preventive services for those who may fall under this umbrella term. The Patient Protection and Affordable Care Act 2010 expands insurance coverage, consumer protections, and access to care and places a greater emphasis on prevention. Currently, various caries preventive strategies are in use, like oral health education, chemical and mechanical control of plaque, use of fluorides, application of pit and fissure sealants, etc. Many of these approaches can be broadly effective. However, economic, behavioral, or cultural barriers to their use have continued the epidemic of dental disease in the mouths of many people on a global level. The latest approach for combating dental caries is through the development of an effective vaccine that is well suited for public health applications, especially in the environments that do not lend themselves to regular health care. The focus of the present review is on the development of a suitable vaccine to prevent dental caries. As dental caries is a multifactorial disease, various modalities exist to prevent it, like the use of fluorides, mechanical and chemical control of plaque, pit and fissure sealants, etc. Nevertheless, for the most part, treatment of the disease is largely limited to removal of the diseased part of the tooth and placing a suitable restoration, and scant attention is paid to controlling the disease itself. Vaccination against caries is based on the idea that the same principles that apply to mucosal immunity are applicable to protection against caries. However, the dilemma is that dental caries occurs not on a mucosal surface, but on a hard, largely non-reactive surface. So how do we treat this epidemic? Although we do not have a vaccine for dental caries yet, we can all work to increase our awareness and improve access to preventive care by being part of treating the caries epidemic. Now that we have defined health and disease, we have identified the CODA standard up to which we are held accountable for training competency. Let us define the word prevention as it refers to oral disease. The contemporary definition of prevention is the art and science of managing the risk factors of each individual patient to promote optimum oral health. The Center for Disease Control and Prevention have a long history of monitoring the use of clinical preventive services to provide public health. Increased use of clinical preventive services could improve the health of infants, children, and adolescents to promote healthier lifestyles that will enable them to achieve their full potential. The Affordable Care Act expands insurance coverage, consumer protections, and access to care for the U.S. population, and places a greater emphasis on prevention. So if an increased use of clinical preventive services could improve the health of infants, children, and adolescents, and promote healthy lifestyles that will enable them to achieve their full potential, how can we increase access and awareness to clinical preventive services? And ultimately, who does it affect in the end? The CDC MMWR report of 2014 has a broad scope and is aimed at several targets: breastfeeding counseling, hearing screening and follow-up, developmental screening, lead screening, vision screening, hypertension screening, dental care and dental preventive service, human papillomavirus vaccination, tobacco use screening and cessation assistance, chlamydia screening, reproductive health services. So although we in our field and our profession are focused on the dental care and dental preventive services, let's not put blinders on and lose sight of the overall goal of the CDC and the Affordable Care Act, which were illuminated through this MMWR report in 2014. Notice that the MMWR report of 2014 evaluated the percentage of persons aged less than 21 years who have visited the dentist and the percentage of persons aged less than 21 years who have received dental preventive services, topical fluoride, sealant, or both. Remember, they did not count a prophylaxis as a preventive service due to lack of evidence, and percentage of persons aged 5 to 19 years who have a dental sealant. The MMWR report of 2014 recommends the American Academy of Pediatrics be a stakeholder in these dental care and dental preventive services. The findings in this supplement indicate that millions of infants, children, and adolescents in the United States have not benefited from key clinical preventive services, and that there are large disparities by demographics, geography, and healthcare coverage and access in the use of these services. A key finding in the report was that more than half children and adolescents did not visit the dentist during the preceding year, and 86% of children and adolescents did not receive a dental sealant or topical fluoride application during the preceding year in 2009. More than 2/3 of 5 through 19-year-olds did not have a dental sealant during 2005 through 2010. Looking at this information in 2015 may seem negligible. What we have here in our crop of these young people who do not receive preventive services for 5 years, so we have a generation of infants, children, and adolescents who will be in severe need of surgical services due to the rampant caries that will affect the mouths of this population. And now we see the problem more clearly, that prevention starts before the child is born and continues throughout the child's life into adulthood and beyond. Dental caries is the most common chronic disease of our children and virtually universal among adults. It is both curable and preventable.